Hello everyone and welcome to this research presentation overview. This research presentation overview, which has been a collaboration in on works that looks at myasthenia gravis as a myasthenia gravis and a review. This research, the preceding works, for this have been a collaborative between students in amongst undergrad in amongst biomedical sciences and pharmacology early postgrad pharmacology students between two academic institutions. Two academic institutions in the United Kingdom, and also where the collaborative was was in around where collaboration was with as part of the RPSG, the Renal Patient Support Group social media platform. So in this research poster presentation, the main basis is in around, again, looking at myasthenia gravis. So the to begin with, some introduction in around this. So the fluctuating nature of myasthenia gravis has historically made it difficult to entirely appreciate, but advances in laboratory and pathology investigations have looked to resolve or are resolving the sort of challenges and ambiguities. Recent studies or investigations utilizing automated video analysis have demonstrated that ocular metrics can help track elements in around some of the symptomologies in around myasthenia gravis, including sort of the acceleration in around aspects of the central nervous system that are affected by the deficits in the acetylcholine receptor, in around the deficits of acetylcholine receptor, and where the objective of for example, digital biomarkers of being integrating into the concept of digital twin, a virtual computational replica of patient constructed from some of the symptomologies in around myasthenia from multi-omics data and continuous continuous sensor inputs. So by stimulating treatment responses on these on the around the concept of digital twins, digital twins and omics, clinicians can and should be able to identify if and whether patients will respond to particular myasthenia myasthenia treatments and or interventions or clinical interventions, including whether patients will respond to thymectomy or require a complement inhibition before a single intervention is administered, and effectively rendering the trial and error approach sort of obsolete in around myasthenia. Then additionally there are then the elements in around sort of the traditional blood science and pathology investigations, which look to which look to effectively determine sort of cell the effects of particular cells and their bases to predict or to predict and inform the short-term and elements of prognoses with more accuracy for the prognoses for the prognoses of those who suffer with myasthenia. So in around some of the aims of this works was where there was an aim to provide or offer a comprehensive overview of myasthenia gravis, encompassing elements of epidemiology, clinical manifestations, immunopathogenesis, histopathology, and some of the biomedical challenges. So now looking in at some of the epidemiology, about approximately or sort of estimated 10 to 15% of myasthenia cases have sort of a juvenile onset of where recipients can be less than 18 years of age, with a mean age of around 13 years at onset, and just under 14 years of age at diagnosis. And juvenile myasthenia gravis, or JMG, differs from adult myasthenia in clinical severity, gender ratio, seropositivity rate, and likelihood of spontaneous remission. Race and pubertal development also influence the disease presentation and progression. So, for instance, most Korean JMG recipients present with pure ocular symptoms or symptomology, while European American investigations or studies have reported predominantly ocular presentation in pubertal onset and generalized disease post-puberty. Pubertal JMG patients or recipients are more often seronegative and exhibit ocular symptoms or symptomologies and show better treatment response than post-pubertal recipients. So now looking at some of the clinical manifestations. So in around particularly the ocular MG and ocular myasthenia, approximately 60% of myasthenia recipients initially present with ocular symptomologies, and nearly all experience them at some stage of the condition. In a subset of recipients, the weakness remains confined to the optics and defining ocular myasthenia regardless of antibody status, thymic pathology, except in thymoma or disease duration, and the condition occurs with similar frequency in individuals positive for anti-acetylcholine receptor LRP4 antibodies, but is rarely seen in those with other antibodies referred to as MuSK. Patients exhibiting ocular weakness but with myasthenia specific abnormalities in non-ocular muscles are also considered to have ocular myasthenia, although they carry increased risk of progression to generalized disease. Long-term follow-up indicates that around 2 years after onset, 15 to 20% of ocular myasthenia recipients continue to show isolated ocular involvement, and in more than 90% of these, the disease remains localized. In around the generalized myasthenia gravis, compared with ocular myasthenia, the generalized myasthenia gravis poses a greater clinical burden due to the risk of crisis and the need for systemic immunotherapy. Modern management increasingly employs targeted agents such as FcRn antagonists and complement inhibitors, which have shown efficacy in refractory cases. In generalized myasthenia gravis, represents sort of a more severe systemic phenotype, requiring timely and intensive therapeutic or pharmacotherapeutics interventions. Generalized myasthenia gravis is defined also as involvement of most skeletal muscle groups beyond the extraocular muscles, independent of disease severity. In around thymus-related myasthenia, thymoma-associated myasthenia, or TAMG, um, represents a distinct immunopathological subtype of myasthenia, closely linked to the presence of thymic epithelial tumors. Approximately 10%, around 10% of all myasthenia cases are thymoma associated, whilst around 30% of individuals with thymoma develop clinically evident myasthenia, and another 15% sort of show acetylcholine receptor antibodies without overt symptoms or symptomologies. Thymoma-associated myasthenia gravis is also specifically associated with anti-acetylcholine, associated with anti-acetylcholine receptor antibodies, and is not typically seen in myasthenia subtypes involving other autoantibodies. So now looking into some of the immunopathogenesis. So myasthenia gravis is a prototypical humoral autoimmune disease that targets the neuromuscular junction, or NMJ, and autoantibodies include acetylcholine receptor, acetylcholine receptor, and muscle-specific kinases, and the abbreviation again is MuSK, and sort of other receptor-related proteins, other receptor proteins. So again, in amongst the literature, there is the receptor LRP4, and autoantibodies attack the postsynaptic membrane and impair neuromuscular junction transmission, resulting in the muscle weakness and fatigue. And signal transmission between nerve terminals and muscle fibers occurs at the neuromuscular junction and requires acetylcholine to be released from the presynaptic terminal. Acetylcholine binds to nicotinic receptors on the postsynaptic membrane, which if generates a sufficient end plate potential, it triggers a muscle action potential, resulting in muscle contraction. Acetylcholine receptors acetylcholine receptors are clustered on neuromuscular junction to ensure signal efficacy, and neuroagrin can bind LRP4, forming a complex with muscle-specific kinase, resulting in muscle-specific kinase phosphorylation and activation, enabling orexin-mediated acetylcholine receptor clustering at the neuromuscular junction. In this research poster presentation, there are two sort of histopathology illustrations, and without going into too much detail, one of the illustrations here, the first illustration looks at the myasthenia axon foot and mitochondria and synaptic vesicles. And the second figure or illustration, or histopathology illustration, or figure looks at the myasthenia abnormal axonal morphology. So listen, those who are listening and all going to, that look to find out about the histopathology are welcome to review, welcome to go over the illustrations or the histopathology illustrations, so that there is familiarity with what for example, histopathologists would normally see in myasthenia patients, in myasthenia patient samples in under laboratory investigations. So so now looking at sort of the ultimately sort of some of the biomedical challenges. So cytokine targeted therapies, particularly interleukin-6 inhibitors, such as tocilizumab and satralizumab, provide sort of alternative monoclonal antibody treatments, treatments and approaches by modulating inflammatory pathways that promote B cell maturation and antibody secretion. Preliminary investigations demonstrate that symptomatic improvement in refractory myasthenia gravis. However, the mechanistic ambiguity whether advantage derives from direct suppression of autoreactive B cell maturation or indirect effects on T cell signaling reflects broader uncertainty about the role of inflammatory cytokines in myasthenia gravis pathogenesis, and the utility of monoclonal antibodies in myasthenia, for example, may ultimately be confined to specific immunological endotypes rather than the myasthenia population, generally. Collectively, biologics have redefined myasthenia sort of pharmacotherapies or therapies by aligning interventions with discrete immunopathogenic checkpoints, complement involvement, and for example, immunoglobulin G or IgG recycling B cell activation. No single pathway dominates, unfortunately, across the subtypes, necessitating more precision matching between therapeutic mechanisms and the immunological phenotype. So that draws this research poster presentation overview to an end. This has been a research poster presentation overview looking at myasthenia gravis, as sort of a review. There are some references or citations that listeners can go into and to find out similar works in around the themes of this research poster presentation and in around myasthenia gravis. Thank you.